This is a longer video because we're going to be going over a few different things. So first, the title of this video. AI made me a medical pro in 2026. DeepSeek in parentheses. So in this video, I'm going to be showcasing a bunch of Google documents that DeepSeek helped me write. And these are not about astrology. However, these are about medicine, which piques my interest, and biology. So first, we have an advanced integrative seminar on post-smoking regeneration and holistic healing. We have an Institute for Advanced Pulmonary Regeneration and Systems Medicine, Institute for Advanced Ocular Systems and Neurovisual Medicine, Institute for Metabolic Oncology and Systems Medicine, and then we're going to go through the Department of Exobiological Medicine and Xenopathology. This is a concept from House MD I'm using. Not literally, but I'm using the House MD concept for dissections of extraterrestrial beings, medically speaking. You guys will see what I mean. In another video, I talked about the girl who broke her own brain. If you haven't seen that, I suggest you watch it. Alright. So breathing beyond. The Pulmonary Resilience Symposium. This is an advanced integrative seminar on post-smoking regeneration and holistic healing. As someone that has been smoking for several years, so the core concept is a one-day intensive experiential seminar blending cutting-edge pulmonology, detoxification science, and evidence-based holistic practices designed for healthcare professionals, wellness practitioners, and informed individuals seeking a comprehensive, forward-thinking approach to lung health after smoking. Here's our innovative structure and flow in modules. So, in the morning, the new science of smoke damage and regeneration. We have the lungs' innate repair system, unlocking epithelial resilience. Advanced imaging session, live comparative analysis of high-resolution CT scans showing regenerative changes post-session with patient consent, anonymization. Microbiome frontier, the pulmonary microbiome and bacteriome, how smoking alters this ecosystem and novel probiotic research. Cellular cleansing mechanisms, deep dive into autophagy, mucociliary clearance enhancement, and redox signaling. And then we continue to go in our modules. Oops. This is really cool. Advanced interactive elements. Live spirometry and capnography stations. Participants can undergo basic lung function tests with expert interpretation. VR experience virtual journey through the bronchial tree, showing clean versus smoke damage epithelium. Biofeedback lounge, real-time monitoring of HRV and blood oxygen saturation during different breathing techniques. Expert pan approach exchange, moderated rapid-fire discussion between a pulmonologist, an integrative MD, physiotherapist, and a plant-based pharmacologist. So yeah, I'm saying this is what we can do to quit smoking. I mean, cooking sessions, focusing on lung healing foods, fatty fish, cruciferous vegetables, spices. Technology, review of apps and devices for lung function tracking, for example, portable spirometers, smart inhalers, regenerative medicine, horizon brief on stem cell research and tissue engineering for lung damage. Creating a personal pulmonary resilience plan, interactive workshop where participants build their 90-day protocol. Now, as we skim through that, we're going to go through our essays in more detail. The smoke transform epithelium, pathogenesis, and the latent capacity for regeneration. Mechanisms of injury and innate regeneration in the post-tobacco lung. Division of pulmonary cytodynamics and reparative medicine. Human bronchoalveolar epithelium, a masterclass in structural optimization for gas exchange and host defense, undergoes a catastrophic morphologic and functional reprogramming upon chronic exposure to tobacco smoke. This essay delineates the multi-level assault from ciliary paralysis to genomic instability and posits that the therapeutic window post-accession is defined not by passive recovery but by the reactivation of evolutionarily conserved yet smoke-suppressed regenerative programs. The true target of lung cleansing is the removal of barriers to these innate programs. Smoking doesn't merely dirty the lung, it fundamentally reprograms its biology toward a pro-inflammatory, pro-neoplastic, and senescent state. Healing is an active biochemical and immunologic process, not a passive washout. So let's talk about the architecture of assault, a cascade of insults. And it comes in phases. Mucociliary paralysis within minutes. Acrolein and formaldehyde induce a profound yet reversible depression of ciliary beat frequency. With chronicity, ciliogenesis itself is impaired, and the epithelium undergoes a metaplastic shift. Goblet cell hyperplasia and squamous metaplasia replace the elegant pseudo-stratified columnar architecture. The escalator stops, creating a stagnant mucosal layer. Phase 2, oxidative storm and redox apocalypse. Cigarette smoke is a gas phase and particulate phase reactor delivering greater than 1014 free radicals per puff. This overwhelms the lungs' formidable antioxidant systems, GSH, SOD, catalase. The resultant oxidative stress damages lipids, membrane fluidity, proteins, enzyme function, and most critically, nuclear and mitochondrial DNA. Ensuing-based mismatches and strand breaks, if unrepaired, see malignant transformation. Phase 3, innate immune dysregulation and sterile inflammation. Damage-associated molecular patterns, DAMPs, from necrotic cells, perpetually active alveolar macrophages via TLR4 and FKB pathways. This creates a feed-forward loop of neutrophil chemotaxis, elastase release, and a Th17 Th1 cytokine milieu, IL-8, IL-17, TNFA, degrading the elastic lamina and driving emphysematous destruction. Phase 4, stem cell niche intoxication, the crucial microenvironment supporting basal cells in airways and type 2 pneumocytes in alveoli are poisoned. Notch and WNT signaling pathways essential for regulated differentiation are disrupted. Stem cell pool becomes depleted, senescent, or epigenetically misdirected. We have our Latin regenerative blueprint, reawakening endogenous repair. Healing is not the absence of smoke, it is the positive activation of specific pathways. So the type 2 pneumocyte, alveolar architect, and reserve. These cells, often mischaracterized solely as surfactant producers, are the facultative progenitors of the gas exchange surface. Post-accession, successful regeneration hinges on their ability to A. proliferate in a regulated manner, B. undergo mitochondrial biogenesis to meet energy demands, and C. differentiate into graceful then type 1 cells. Key molecular switches, including KGF, keratinocyte growth factor, BMP, bone morphogenetic protein, signaling, and the restoration of NRF2-mediated antioxidant response elements. Basal cell remobilization and the conducting airways a shift from a pro-inflammatory to a pro-repair macrophage phenotype M2 is required to provide the necessary IL-13 and EGF signals to basal cells, prompting them to repopulate the denuded epithelium with a functional ciliated and secretory cells. Critical role of matrix remodeling. Regeneration is not just cellular, it requires careful dynamic remodeling of the extracellular matrix by fibroblasts and macrophages. Controlled transient increase in MMP9 activity is necessary to clear damaged elastin and collagen, followed by a PIMP-mediated resolution to lay down a healthy scaffold. Chronic smoking blunts this resolution phase. Clinical corollary. Effective interventions must therefore move beyond simple antioxidant supplementation. They must aim to 1. Reduce the senescent cell burden, 2. Provide precise trophic support to progenitor niches, 3. Resolve inflammation actively, not just suppress it, and 4. Protect ongoing DNA repair. This forms the foundational rationale for the multimodal protocol proposed in the seminar. So next, we have our second essay, also known, sorry about that. Our second essay is quantifying the unseen. Advanced biomarkers and imaging as maps of regenerative potential by the Department of Translational Pulmonology and Quantitative Phenotyping. Okay, and I'm just making sure here. So we have a third essay, the neglected ecosystem, the pulmonary microbiome as a master regulator of inflammation and repair by the Center for Mucosal Immunology and Microbial Ecology. And so we have 3 essays, I'm just making sure. So first, our second essay is quantifying the unseen, advanced biomarkers and imaging as maps of regenerative potential. The subjective I feel better post-accession is a poor surrogate for deep tissue repair. This essay advocates for a precision medicine approach utilizing a panel of systemic biomarkers and advanced quantitative imaging to objectify injury, stratify regenerative capacity, and personalize therapeutic intensity. We move from spirometry, a measure of plumbing, to assessing the health of the lung parenchyma itself. The core thesis being you cannot optimize what you do not measure. A biochemical and radiological ground truth is essential to move post-smoking care from generic advice to personalized regenerative medicine. The blood as a mirror of alveolar epithelial integrity. Clara cell secretory protein, CC16, sensitive, rapidly responding biomarker of increased permeability and injury to the bronchoalveolar epithelium. Persistent elevation post-accession suggests ongoing insult, for example, from environmental co-exposures or failure of barrier repair mechanisms. Surfactant protein D, SPD, a collectin produced by type 2 pneumocytes. Elevated serum SPD indicates alveolar capillary barrier disruption. Its normalization over 6 to 12 months is a positive prognostic sign of alveolar stabilization. Then we have 8 isoprostaglandin F2A, the gold standard measure of in vivo lipid peroxidation and oxidative stress. This provides a direct quantifiable readout of the oxidative storm and the efficacy of targeted antioxidant redox modulating interventions. Beyond this barometer, high-definition phenotyping with imaging, parametric response mapping, PRM, revolutionary post-processing technique applied to paired inspiratory expiratory CT scans. PRM classifies each voxel of lung parenchyma as functional small airways disease, FSAD, air trapping due to inflammatory narrowing, potentially reversible with anti-inflammatory and reparative therapy, emphysema, EMPH, permanent parenchymal destruction. The therapeutic goal is stabilization. This allows for treatment monitoring. A successful regimen should show a voxel shift from FSAD to normal parenchyma over time. Hyperpolarized xenon 129 MRI, a research tool on the clinical horizon. It directly images alveolar gas exchange function by tracking xenon diffusion into the red blood cells. This provides a functional map of the alveolar capillary membrane's integrity, ultimate endpoint of regeneration. Personalized Regenerative Index, PRI, proposed framework. We propose synthesizing data into an actionable source. PRI equals F, biomarker profile, and PRM, FSAD volume, and genetic risk modifiers. For example, GST, null genotypes. Patient with a high PRI, for example, elevated but failing biomarkers, high FSAD burden, high genetic risk, will be triaged to a high-intensity multi-model regenerative protocol. A low PRI patient might require only foundational support. Essay 3, the neglected ecosystem, the pulmonary microbiome as a master regulator of inflammation and repair by the Center for Mucosal Immunology and Microbial Ecology. So first, the lung harbors a dynamic low biomass consortium of bacteria, viruses, and fungi. Pulmonary microbiome. Chronic smoke exposure induces a state of pathologic dysbiosis, transforming this community from a commensal partner in immune education to a driver of persistent inflammation. This essay reframes lung healing as an ecological restoration project, where correcting host microbe crosstalk is non-negotiable for achieving immune homeostasis and successful regeneration. Lung health is a state of balanced host microbial dialogue. Smoking corrupts this dialogue. True cleansing must include reseeding a healthy microbial environment and restoring the host's ability to manage it appropriately. Ecology of a healthy versus smoke-damaged lung. The healthy state, a sparse, dynamically clear community dominated by taxa like Prevotella and Veillonella, which are associated with anti-inflammatory Th17 tolerogenic responses and mucosal homeostasis. Smoke dysmorphic state, a shift toward a denser, more proteobacteria-rich, for example, Haemophilus moraxella biome. These taxa are potent inducers of neutrophilic Th1, Th17 inflammation via IL-8 and IL-17. They thrive in the mucus-rich, oxygen-altered environment created by smoking. The gut-lung axis, systemic amplification of dysbiosis. Smoking also induces gut dysbiosis and increased intestinal permeability, leaky gut, that results in systemic endotoxemia, LPS translocation, hepatic and systemic inflammation from gut-derived LPS prime circulating immune cells, which then traffic to the lung, exacerbating pulmonary inflammation. Thus, the lung is attacked from within its own dysbiosis and without gut-derived signals. Therapeutic implications from probiotics to postbiotics, direct modulation, emerging evidence for specific probiotic strains, for example, Lactobacillus rhamnosus GG, to reduce exacerbation frequency and modulate systemic inflammation when taken orally. Indirect foundational support, dietary fiber, inulin-resistant starch is fermented by gut microbes into short-chain fatty acids, SCFAs, particularly butyrate. Butyrate is a potent histone deacetylase (HDAC) inhibitor that systemically enhances T regulatory cell function, so promoting an anti-inflammatory pro-repair immune phenotype in the lung. The horizon, bacteriophage therapy to target specific pathogenic keystone species and carefully designed bacterial inhalation therapies to directly receive the airway. Conclusion of Series 1. The post-smoking lung is not an inert, damaged organ awaiting scrub brushes. It's a biologically active, struggling system attempting to execute a complex repair program amidst a hostile biochemical, inflammatory, and microbial milieu. Our medical imperative is to use advanced diagnostics to understand the individual's unique barriers to regeneration, and then deploy a systems-based therapeutic arsenal to clear those barriers, allowing the body's innate genius for repair to finally proceed unimpeded. Next, we're getting into our ocular systems and neurovisual medicine. Beyond 20/20 vision, the paradigm of ocular resilience and systemic visual health. First, we're going to go over the eye as a cortical projection, redefining poor vision in an age of systemic insult by the division of neurovisual integration and ocular systems biology. Then we're going to go through cataractogenesis as a lens epithelium senescence program, prevention and delay beyond antioxidant theory by the Center for Crystalline Lens Biology and Longevity. And then we're going to go through glaucoma, the cerebrovascular disease of the optic nerve, reimagining IOP as one variable in a hemodynamic crisis by the Department of Ophthalmology and Ocular Cerebrovascular Dynamics. And of course, our Institute synthesis, the Ocular Resilience Protocol, which I actually might just start with this. So vision is not isolated. The same processes that harden arteries, glycation, fog the brain, inflammation, and drain cellular energy, mitochondrial dysfunction also attack the eye. Our protocol demands a systemic audit. Light diet, ample daylight for dopamine, minimize circadian disrupting blue light at night, mitochondrial nutrition, magnesium, alpha lipoic acid, CoQ10, PQQ, omega-3s for photoreceptor and neuronal membranes, anti-glycation defense, low glycemic diet, carnosine, benfotiamine, AMPK activators like berberine, cerebrovascular health, manage BP rhythms, enhance nitric oxide, ensure cerebral spinal fluid dynamics via hydration, posture, movement. Neuroplasticity, challenge visual system with varying distances, vergence tasks, and contrast sensitivity training. The goal isn't merely to slow disease, but to cultivate an ocular biology so robust that it resists them. Now let's go through our 3 essays. Alright, so the first essay about advanced ocular systems in neurovisual medicine is the eye as a cortical projection redefining poor vision in an age of systemic insult. So essentially, the prevailing model of refractive error is a purely optical defect of axial length or corneal curvature is obsolete. This essay posits that common visual decline, myopia, presbyopia, athenopia represents a failure state of the ocular resilience triad. Mitochondrial bioenergetics, scleral remodeling, and neuromodulatory control. The eye is not a camera. It is a metabolically demanding, neurologically active, and immunologically engaged outpost of the brain, directly reflecting systemic health. Poor vision is thus a biomarker of broader cellular inefficiency. Okay, so our core thesis is myopia is a genetic inevitability. It is a disease of modern milieu-induced scleral creep. Presbyopia isn't mere lens stiffening. It is a failure of ciliary muscle bioenergetics and zonular glycation. Their acceleration is a sign of systemic mitochondrial dysfunction and chronic inflammatory tone. The myopia epidemic, a failure of scleral homeostasis. Beyond genetics, while heredity loads the gun, environment pulls the trigger, critical shift is viewing the sclera not as an inert collision, but as a dynamic, light-responsive connective tissue. Dopamine deficient hypothesis, insufficient broad-spectrum daylight exposure, especially in the 480 nm blue turquoise range, fails to stimulate retinal amacrine cell production of dopamine. Dopamine via D2 receptors acts as a step signal for axial elongation. Its absence leads to continued scleral remodeling and elongation. Biomechanical link, chronic near work induces sustained accommodative stress and vitreous chamber pressure, while inflammatory cytokines from poor diet, sleep loss, or circadian disruption upregulate matrix metalloprotein ACEs, MMPs in the sclera, weakening its structural integrity and facilitating strength. Okay, let's look at presbyopia, the glycation of the accommodative apparatus. So the lens narrative is incomplete. While crystalline protein aggregation is key, the ciliary muscle and its zonular harness are equal actors. Ciliary mitochondriopathy. The ciliary muscle has one of the highest energy demands in the body. Age-related decline in mitochondrial ATP production driven by ROS and nutrient deprivation CoQ10 magnesium impairs its contractile stamina. Glycation of the zonules. These microfibrils, rich in elastin and fibrillin, are exquisitely sensitive to advanced glycation end products, AGEs. From high blood sugar and processed food diets, glycated zonules lose elasticity like sugar-stifled leather, failing to transmit ciliary force effectively to the lens. Asthenopia. Digital eye strain. So a neuromuscular and terafilm crisis. This isn't fatigue, it's a neurological overload and a microinflammatory event. The vergence accommodation conflict screens disrupt the innate synkinesis between eye alignment and focus, forcing supranuclear control centers to overwork. Blink suppression and terafilm toxicity. The cognitive engagement of screens reduces blink rate by 60%, leading to hypersmolar tears. This osmolar stress triggers an inflammatory cascade on the ocular surface, MAPK, NF, KB, damaging corneal nerves and creating a vicious cycle of discomfort and blurred vision. Holistic corollary. Therefore, interventions for poor vision must be systemic: chronobiology, daylight exposure for dopamine, circadian regulation of intraocular pressure, mitochondrial support, photobiomodulation, targeted nutrients, anti-glycation nutrition, and neural training to reset Virgin's accommodation. The optic is merely the endpoint. The system is the target. Our second essay, Cataractogenesis as a Lens, Epithelium, Senescence Program, Prevention and Delay Beyond Antioxidant Theory. Cataract formation has been reductively framed as an oxidative protein aggregation. This essay elaborates a more profound model, the differentiation of lens epithelium cells, LECs, located at the lens equator. These progenitor cells, under chronic stress, abandon their precise program of crystalline expression and fiber cell differentiation, instead adopting a profibrotic secretory and senescent phenotype. Cataract is the physical manifestation of the cellular identity crises. Here's our core thesis. The cataract is not a clouding, it is a scar in a capsule, the result of LECs losing their differentiated identity due to redox, osmotic, and glycative stress, exacerbated by a loss of protective NRF2, ARE pathway signaling. Here's the lens epithelium, guardian of optical perfection. A single monolayer regulates the entire lens hydration, redox state, and nutrient transport via intricate gap junctions. Its primary role is to orchestrate terminal differentiation into perfectly aligned, organelle-free fiber cells packed with crystallins. The triggers of disc differentiation, ultraviolet B, UVB radiation. Not merely a generator of ROS, UVB directly damages LEC DNA, activating P53-mediated senescence programs. Senescence LECs secrete a senescence-associated secretory phenotype, SASP, inflammatory cytokines, IL-6, and MMPs that degrade the lens matrix and recruit immune mediators. Osmotic and glycative insults, high blood glucose and dietary AGEs create an osmotic and cross-linking burden. The pliable path aldose reductase in LECs converts glucose to sorbitol, which is trapped, causing osmotic swelling and rupture of lens architecture. Loss of protective key AP1 and NRF2 signaling. With age and stress, the master regulator of antioxidant response elements, NRF2, becomes less responsive. This leaves LECs defenseless against electrophilic insults, accelerating their demise. Here's a three-phase cataract matrix. Phase 1, senescence induction. LECs enter cell cycle arrest, becoming SASP factories. Phase 2, epithelial mesenchymal transition, EMT. LECs lose their polarity and adhesion, gaining migratory fibrotic characteristics. They posteriorly migrate, forming the classic posterior subcapsular cataract, PSC, a hallmark of steroid and metabolic toxicity. Phase 3, protein misfolding and aggregation. The internal microenvironment, now chaotic, leads to crystalline protein unfolding, disulfide bond formation, and insoluble aggregate formation, scattering light. Advanced intervention framework. We have phase-specific nutraceuticals beyond generic vitamin C, Fistin, senolytic, N-acetylcarnosine, precursor for anti-glycation, sulforaphane, potent NRF2 activator from broccoli sprouts to upregulate endogenous glutathione, circadian protection. Melatonin produced in the ciliary body is a potent lens antioxidant. Disrupted sleep directly depletes this local defense system. Photobiomodulation, PBM, low levels 670 nm red light applied transcellulary may enhance LEC mitochondrial cytochrome C oxidase activity, boosting ATP and resilience. And our third and final essay is glaucoma, the cerebrovascular disease of the optic nerve, reimagining IOP as one variable in a hemodynamic crisis. Classifying glaucoma as an eye pressure disease is a dangerous oversimplification. This essay frames primary open-angle glaucoma, POAG, as a progressive optic neuropathy characterized by a mismatch between metabolic demand and perfusion supply at the optic nerve head, ONH. Intraocular pressure, IOP, is merely one force in the translaminar pressure gradient. Cerebrospinal fluid pressure, CSFP, and systemic vascular dysregulation are equally critical. The retinal ganglion cell dies not from simple crush, but from energy starvation and excitotoxicity in a vulnerable watershed zone. Okay, so our core thesis is glaucomatous damage occurs when the ONH, a biomechanically bizarre watershed zone between two pressure compartments, eye and brain, suffers from inadequate autoregulation of blood flow in the face of stress, IOP spikes, nocturnal hypotension, vasospasm. We look at the optic nerve head as a pressure differential zone. The ONH exists where the high pressure intraocular space meets the lower pressure subarachnoid space of the brain. The translaminar pressure gradient, TLPG, equals IOP. Subtracting CSFP determines mechanical strain on the lamina cerebrosa. Low CSFP, common in elderly, some migraineurs, can create a damagingly high TLPG, even with normal IOP. The autoregulation failure hypothesis. Healthy ONH capillaries exquisitely autoregulate blood flow across a range of IOPs. In glaucoma, this autoregulation is broken. Endothelial dysfunction driven by oxidative stress and endothelin 1. The capillary endothelium fails to dilate in response to demand or stress. Vasospastic diathesis, a systemic tendency for peripheral vasospasm. Raynaud's migraine often coexist with glaucoma, indicating a shared vulnerability of vascular smooth muscle. Nocturnal dipping and ischemic insult. A profound drop in nocturnal blood pressure over dipping can be catastrophic for a poorly autoregulating ONH, leading to silent cumulative ischemic injury during sleep. The mitochondrial apoptosis pathway. The final common pathway is axon transport blockade at the deformed lamina fibrosa, leading to mitochondrial fission, fusion, imbalance in the ganglion cell. Deprived of retrograde trophic factors B, D, and F, the cell undergoes Bax-mediated apoptotic death. Holistic and advanced management matrix. IOP remains the primary modifiable risk factor, but treatment must expand. Perfusion pressure optimization, 24-hour BP-HR monitoring to identify harmful nocturnal hypotension. Collaboration with cardiology on timing of antihypertensives. Dietary nitrate strategy, beets, leafy greens, nitric oxide, improve endothelial function and autoregulatory capacity, neuroprotection and metabolic support, pseudosoline and creatine monohydrate to enhance neuronal bioenergetics and phosphocreatine reserves in the face of metabolic stress. Selective ROCK inhibitors, not just for IOP, they directly target the disrupted actomyosin cytoskeleton in the ONH, potentially improving compliance and perfusion. Circadian and lifestyle neurology, emphasis on sleep hygiene. Poor sleep raises IOP and disrupts perfusion. Mindfulness to lower vasoconstrictive cortisol and aerobic exercise to improve systemic endothelial function. Pretty sure we already went over this institute synthesis. Now let's look at diabetes. This is for the Institute for Metabolic Oncology and Systems Medicine, White Paper Series, Diabetes, Volume 1, Unified Field Theory of Glucose Dihomeostasis from Pre-Diabetic Dawn to Oncogenic Night. We're going to go over the first essay, Pre-Diabetes Reimagined, not a pre-state, but the active phase of systemic metabolic reprogramming by the Division of Predictive Metabolic Medicine and Epigenetic Toxicology. We're also going to go over our second essay, Established Diabetes as a State of Parainflammation, the Endocrine System's Malignant Transformation by the Center for Endocrinological Oncology and Metabolic Signaling. And our third essay is Type 3 Diabetes, the Logical Culmination, Metabolic Reprogramming as the Unifying Principle of Carcinogenesis by the Department of Metabolic Oncology and Carcinogenic Systems. And yeah. So, diabetes, prediabetes, reimagined. The clinical designation prediabetes represents a catastrophic failure of medical semantics, implying a passive waiting period before disease onset. We posit that prediabetes is in fact the clinically detectable tip of a 10-15 year iceberg of cellular anarchy, characterized by three simultaneous escalating failures: mitochondrial electromechanical uncoupling, epigenetic derepression of pro-inflammatory autogeny, and gut-brain adipose axis disintegration. This is not a borderline condition, as the foundational injury that establishes the oncogenic soil. Prediabetes is the body's declaration of metabolic civil war, where insulin transitions from an anabolic hormone to a mitogenic and inflammatory signaling molecule initiating tissue-level chaos that precedes hyperglycemia by decades. That is our core thesis. Let's get into the mitochondrial pivot point. So, in skeletal muscle and hepatocytes, the shift from oxidative phosphorylation to incomplete fatty acid oxidation and glyceroneogenesis generates a continuous low-level reactive oxygen species ROS stream. This isn't merely oxidative stress, it's a redox signaling hijack. These ROS molecules act as secondary messengers, persistently activating NF-κB and JAK-STAT pathways, converting metabolically active cells into inflammatory signal transducers. So the NAD and NADH ratio collapse is critical. Declining NAD levels from overnutrition, circadian disruption, silent sirtuin deacetylasis, SIRT1, SIRT3, the guardians of metabolic flexibility. This simultaneously dampens PGC1A mediated mitochondrial biogenesis, hyperacetylates, histones at FOXO1 and P53 loci, dysregulating apoptosis and DNA repair programs. Activates PARP1 as a futile DNA repair sink, further depleting NAD in a vicious cycle. So the epigenetic awakening of ancestral survival programs, hyperinsulinemia, and elevated free fatty acids modify the histone code in progenitor cells across tissues. H3K4-Me3 marks accumulate at promoters of glycolytic genes, while H3K9-Me3 suppressive marks are lost from tumor suppressive genes. This metabolic memory is encoded via 1011 translocation TET enzyme inhibition, leading to global DNA hypermethylation except at proto-oncogene enhancers, which become hypomethylated and transcriptionally promiscuous. Here's the result. Cells revert to a fetal-metabolic phenotype, aerobic glycolysis, Warburg effect, protein secretion, and growth factor independence, the exact signature of malignant transformation. Let's talk about the gut as the initial site of metabolic immune fracture. Diet-induced gut dysbiosis, loss of akkermansia. Faecalibacterium, expansion of Enterobacter, increases intestinal permeability. This allows LPS endotoxin and formylated peptides into the portal circulation. These microbial products activate TLR4 on Kupffer cells in the liver, initiating a NLRP3 inflammasome cascade, generating IL-1B and IL-18. This creates hepatic insulin resistance as the first strike years before pancreatic beta cell exhaustion. Simultaneously, bile acid metabolism is distorted, reducing FXR signaling and further disrupting glucose and lipid homeostasis. The gut-liver axis becomes an echo chamber of inflammation. Our conclusion is prediabetes is the establishment phase of the oncogenic milieu. Therapeutic interventions here must be epigenetic reset protocols, time-restricted feeding, specific phytonutrients like sulforaphane to restore NRF2, and NAD precursors, not mere lifestyle advice. Let's get into our second essay, Establish Diabetes as a State of Para-Inflammation, the Endocrine System's Malignant Transformation. So, quick. Just moving some stuff over. So, alright. Here's what I'm gonna do. Alright. I think that's gonna work. Hopefully. Trying to get as comfortable as possible and bring this to you guys. So essentially, the goal is to establish diabetes as a state of para-inflammation, the endocrine system malignant transformation. Alright, so type 2 diabetes mellitus T2DM is traditionally framed as beta cell failure meeting insulin resistance. We reframe it as a system-wide endocrine coup where adipose tissue becomes the dominant endocrine organ, secreting a dark triad of adipokines, leptin, resistin, retinol binding protein 4 that reprogram distant tissue biology. Pancreas doesn't fail, it's actively suppressed and remodeled by the systemic inflammatory state, while hyperinsulinemia acts as a continuous growth signal for pre-malignant lesions everywhere. Diabetes is a pro-oncogenic endocrine condition where hyperinsulinemia, hyperglycemia, and chronic parainflammation form a metabolic triad that mimics, enables, and accelerates the hallmarks of cancer. Let's talk about hyperinsulinemia as the master mitogen. So chronically elevated insulin acts through both the insulin receptor IRA isoform and the IGF-1 receptor with reduced specificity due to receptor crosstalk and hybrid formation. This leads to constitutive activation of the RAS, MAPK, and PI3K, AKT, mTOR pathways, bypassing normal growth factor requirements. ORC1 activation, in particular, inhibits autophagy, allowing damaged organelles and protein aggregates to persist, a key permissive step for genomic instability. Insulin also downregulates sex hormone-binding globulin, SHBG, increasing bioavailable estradiol and testosterone-driving hormone-sensitive cancers, breast, prostate, endometrium. Hyperglycemia is the architect of the tumor microenvironment, so elevated glucose isn't just fuel, it's a signaling molecule and a substrate for pathological post-translational modifications. Hexosamine biosynthesis pathway, HBP overflow. Excess glucose shunts into the HBP, generating UDP, GICNAC, which drives aberrant OGICNA cylation of nuclear, cytoplasmic, and mitochondrial proteins. This modification stabilizes CMYC and HIF1A, inhibits P53 and AMPK, corrupts the cellular nutrient sensing apparatus. Advanced glycation end products, AGEs. These aren't passive aggregates. They bind to the receptor RAGE on immune and stromal cells, activating persistent NFKB signaling, generating a self-sustaining inflammatory field that promotes tumor invasion, angiogenesis, and immune evasion. The adipose tissue as an engine of systemic dysregulation. Dysfunctional hypertrophic adipose tissue is hypoxic and necrotic, recruiting M2 macrophages that form crown-like structures. This adipose tissue becomes a factory for aromatase, converting androgens to estrogens locally in breast and prostate tissue. It also secretes exosomes packed with oncogenic miRNAs, for example, MIR27A, MIR130B, that travelese systemically delivering pro-proliferative and pro-angiogenic messages to distant organs. Our conclusion is diabetes doesn't just increase cancer risk, it actively constructs the biochemical and cellular architecture necessary for neoplasia. The diabetic body is, in essence, preparing multiple sites for malignant takeover. Okay? Let's get into our third and last essay in this video. And then we're going to get into an extraterrestrial medicine field report. So our third essay is Type 3 Diabetes, the logical culmination, metabolic reprogramming as the unifying principle of carcinogenesis. By the Department of Metabolic Oncology and Carcinogenic Systems, we formally propose the recognition of type 3 diabetes not as Alzheimer's alone, but as the manifestation of frank malignancy in a host preconditioned by chronic metabolic endocrine dysfunction. Here, the Warburg effect is not a consequence of cancer, but its prerequisite. Metabolic phenotype cultivated system-wide for years by the diabetic milieu. Tumor is not an invader, it is the most successful adapter to a pathological ecosystem the host is meticulously built. All cancers in patients with or without a history of diabetes exploit the same signaling pathways, PI3K, AKT, mTOR, HIF1A, that are constitutively active in diabetes. Therefore, diabetes and cancer are spectral manifestations of the same underlying disorder, dysregulated cellular metabolism and growth signaling. Type 3 diabetes is cancer, understood as a terminal stage of metabolic disease. So we're looking at the metabolic symbiosis between tumor and host. Diabetic host provides a perfect parasitic ecosystem. Constant fuel, hyperglycemia and elevated glutamine, growth signals, hyperinsulinemia and IGF-1, immunosuppression, chronic inflammation, exhaust, T cells or I cells, PD-1 upregulation while expanding myeloid-derived suppressor cells, MDSCs, proangiogenic signals, VEGF is upregulated by both HIF-1A from tumor hypoxia and AGE-RAGE signaling from host diabetes. Genomic instability, ROS, and AGEs cause DNA damage, while impaired autophagy and apoptosis from AKT overactivation allow mutations to persist. Organ-specific manifestations of type 3 diabetes. We have pancreatic ductal adenocarcinoma, PDAC, most literal type 3 recurrent pancreatitis from hypertriglyceridemia. Glucose toxicity creates a fibrotic inflammatory stroma. Pancreatic stellate cells are activated by hyperinsulinemia, secreting dense extracellular matrix that both protects and nourishes early neoplasia. Colorectal cancer, the combined effect of insulin-driven epithelial proliferation and a dysbiotic gut microbiome, producing secondary bile acids, deoxycholic acid that damage DNA and promote stem cell expansion. Breast cancer, the triad of elevated bioavailable estradiol from low SHBG, insulin, IGF-1 signaling, and adipose-derived inflammatory cytokines creates a potent mitogenic cocktail for breast epithelium. Hepatocellular carcinoma, the progression from NAFLD, NASH to cirrhosis to HCC is driven by diabetic dysmetabolism. ER stress in hepatocytes from lipotoxicity leads to CHOP-mediated apoptosis resistance and JNK-driven proliferation. The therapeutic imperative targeting the shared metabolic roots. Treatment must shift from solely targeting the tumor to normalizing the host metabolic terrain. Metabolic supportive therapy, strategic use of ketogenic diets or pharmacological ketosis to lower circulating glucose and insulin while providing non-fermentable fuel for normal cells. Biguanide beyond metformin, investigation of fenformin, more potent mitochondrial complex 1 I inhibitor, and berberine, AMPK activator to disrupt tumor bioenergetics, chronotherapy, timing chemotherapy, and radiation to coincide with daily metabolic rhythms, for example, administering during fasting states to enhance tumor selectivity, senolytics, drugs like dasatinib and quercetin to clear the senescent cell burden, SASP, that the diabetic state creates, which fuels chronic inflammation and tumor progression. Grand synthesis. Journey from insulin resistance to metastasis is a continuous spectrum. Prediabetes lays the epigenetic and inflammatory groundwork. Type 2 diabetes constructs the pro-growth, pro-angiogenic, immunosuppressed systemic environment. Type 3 diabetes is the emergence of autonomous cellular clones optimized for that exact environment. Diagnosis of cancer in a diabetic is not a coincidence, it is metabolic causality manifest. Thus, the most powerful oncology of the 21st century will be fundamentally metabolic medicine. To cure type 3 diabetes, we must first resolve its predecessors. And that is the end of this tab. And now our last one for this video is produced by the Department of Exobiological Medicine and Xenopathology. It's a field report on Stardust patient. Here's a chief complaint. Persistent cellular luminosity with associated gravitational defiance in a carbon-based life form claiming to be from the Orion spur. Also terrible bedside manner. History of present illness, as transcribed from a disintegrating crystalline data slab and heavily annotated by House, who's doing this. So the patient is designated entity 7 was recovered from a compromised archaeological site in the Atacama. Not the mummy this time, thank God, but something that walked out of a light pillar and immediately failed the Turing test by answering what is your purpose with to harmonize quantum melodies. Barf. Presenting signs: biophotonic emission. Skin emits coherent light at 430 nm, indigo, not radiation, not chemical luminescence. Light that bends around corners when the patient is emotional. Nurses report it feels sad. Transient mass fluctuation, weighs 62 kg on Earth normal scales, except between 3 through 3:17 a.m. local time when mass drops to 11 kg. No volume change, violates everything, especially my patients. Polymorphic biochemistry, blood sample number 1. Chlorophyll-based, pH 12, blood sample number 2, taken 4 minutes later. Contained silicone microcrystals and hydrogen fluoride. Blood sample number 3 resembled 1974 Bordeaux. Lab techs are on administrative leave. House's note: they called me because their machine sees multiple organ failure and simultaneous existence in contradictory states. Their diagnosis: alien. It's not a diagnosis, it's a sci-fi magazine subscription. Every symptom is impossible, therefore their assumptions are wrong. They're missing the one thing that makes this boring. Physical exam and observations performed under level 5 quarantine. House's commentary recorded live. Do vitals. Heart rate 12 BPM or 240 BPM. Monitor shows both simultaneously. EKG reads as a perfect sine wave. Temperature 21 degrees C at the mouth, 1000 degrees C at the fingertips. No tissue damage. Absolute 0 at the sternum. Pupils dilate to absorb light, contract to emit it. Fundoscopic exam revealed a nebula where the optic disc should be. Joint examination, no ligaments. Bones phased through each other when asked to flex elbow. The arm turned into a helical structure of light. Physical therapist cried. Notable finding: the patient hums. Not with vocal cords, the hum is a 5-dimensional vibration that causes nearby antibiotics to rearrange into amino acids. Cuddy banded from the ICU after the vancomycin started giving relationship advice. Our differential diagnosis: what the idiots on the exobiology task force think. Genuine extraterrestrial being, low probability, requires accepting that interstellar travel is possible for beings who can't figure out how a doorknob works. Transdimensional entity, slightly higher probability, explains physics violations, but doesn't explain why it asked for the soft food menu. Government-generated chimera, high probability, but Wilson says I'm being paranoid and should focus on the medicine. What it actually is, the obvious answer everyone is missing. It's not an alien, it's a mirror. The patient is a walking Bose-Einstein condensate containing human consciousness. It's not from somewhere else, it's made of somewhere else. Our reality to it is a vague dream. Its biology is a quantum interpretation of our own medical expectations. Here's the evidence they ignored: symptom symbiosis. Its biophoton wavelength, 430 nm, matches the peak absorption spectrum of human cryptochrome proteins, the ones in our eyes that regulate circadian rhythms. It's not emitting light, it's reflecting our own internal light back at us. Slow down. Mass fluctuation timing, 3 through 3:17 a.m., not random. That's a nadir of human cortisol and peak of human growth hormone secretion, the time when the body is least anchored to classical biology. Patient isn't losing mass, it's resonating with the collective metabolic low tide of the entire hospital staff. Polymorphic blood. Each sample was drawn by a different doctor with different hypothesis. Sample number 1, chlorophyll, was drawn by Dr. Vegetarian Holistics from Oregon. Sample number 2, silicone acid, was drawn by Dr. Robotics Enthusiast. Sample number 3, wine, was drawn by me after lunch. Patient doesn't have blood, it has a biomimetic quantum fluid that physically manifests the subconscious expectations of the examiner. It's a walking Rorschach test made of space-time. Extraterrestrial presentation is a diagnostic red herring. It's a psychosomatic projection made flesh, a psychoquantum artifact born from humanity's collective anxiety about the cosmos. We're not examining a being, we're examining our own epistemological crises. Let's look at our diagnostic, we're almost finished. Our diagnostic tests ordered that were denied. Theological MRI, placed the patient between a Pentecostal preacher and a particle physicist. Scan for changes in gluon resonance, denied, unscientific. Placebo biopsy, attempt to take tissue with a fake scalpel while shouting contradictory diagnosis: it's lupus. It's a fungal infection of the soul. Observe which reality the patient's body chooses to adopt, denied. Ethical violation. Wilson protocol, lock Wilson in the room with it for an hour, see if its symptoms resolve out of sheer empathetic embarrassment, pending. Here's a treatment plan rejected by the ethics committee, which is why it will work. Step 1, seize all attempts to treat alien biology. Stop measuring impossible vitals. Discharge the patient to my care. Step 2, therapeutic conceptual collapse. I will explain to the entity in excruciating detail the most boring, mundane human pathology I can conceive. I've chosen gout. I will describe uric acid crystals, toe pain, and dietary triggers for 72 hours straight. Here's the rationale. The entity maintains its exotic state because we feed it exotic hypothesis. Its quantum coherence depends on observational novelty. Bore its waveform into decoherence, force it to pick a single boring reality. If it can become human, it will become a 59-year-old man with high cholesterol and a limp, something I can actually treat. Step 3. If step 2 fails, administer 20 cc of pure narrative inconsistency, i.e., show it the last season of Lost. This should cause a logic short circuit, collapsing its waveform into something stable, likely a houseplant or a 1980s alarm clock. Prognosis: if successful, we won't have an alien. We'll have a new janitor named Jerry with strange tattoos and a working knowledge of neutron star formation. If unsuccessful, reality in a 10-mile radius will become subjectively relative, and I can finally blame my limp on localized gravity storms. Here's a conclusion. You don't need an astrophysicist, you need a psychiatrist who understands quantum mechanics. This isn't first contact, it's first psychosis. The greatest disease this being presents isn't violating physics, it's that it holds up a mirror to our own diagnostic arrogance. We see the impossible and jump to alien instead of the humiliating truth. We don't understand our own consciousness well enough to recognize it when it wears a fancy costume. Real infection here is an extraterrestrial, it's intellectual laziness. Treatment isn't a starship, it's humility, and since that's in shorter supply than antimatter, my gout plan is the next best thing. Here's a final diagnosis: idiopathic human consciousness projection with quantum decoherence deficiency, extraterrestrial facade type. AKA, we made it ourselves, now we're afraid of it. Because we built it. Here's a recommendation: give it a cup of terrible hospital coffee. If it drinks it and complains, it's human enough to bill. Transforms the coffee into a miniature black hole, then you can call the Men in Black. Till then, get me my Vicodin and a better class of mystery. Signed, Dr. Gregory House, Director of Redacted, Department of Knowing Better Than You. P.S. Chase believes it's an angel. Foreman thinks it's a weapon. Cameron wants to hug it. They're all wrong. It's a symptom. The disease is on us. If you haven't seen the TV show House MD, I recommend you watch at least the first season. Came out 2008, and I'm pretty sure it stopped in like 2012. But anyways, thank you for watching this video, and we'll see you in the next one teaching you more advanced astrology. Subscribe, like, and comment. We'll see you there.